Okay, thank you very much, Dr. Mohammed, for this great presentation. Now we would like to start our question and answer sessions. Okay, we received lots of questions, by the way, but because of the limited time we have, I don't think we'll be able to answer all questions. We'll start with the first question to Dr. Syed Irteza.
Sure.
Would you proceed with thrombectomy in an M2 occlusion with good collaterals and an NIH score of 5, which is less than one point for all clinical trials? Because their kickoff NIH was 6.
Of course, of course.
Yeah.
So it depends on obviously if it's disabling symptoms or not, status of TPA, if thrombolysis is on board. As of right now, the evidence is mainly for large vessel occlusions. Once we get into M2s, the proximal M2 is still considered by most interventionalists an extension of large vessel. And these patients can deteriorate, and sometimes they have significantly disabling symptoms. So if they're an NIH of 5, but they're aphasic and have motor weakness, I would entertain that, and I would take them for thrombectomy. But there are a lot of case series and registries. I think Dr. Raul Noguera's group, Diego Hausen's group from Emory University have published a good registry on medium vessel occlusions. And I think it has to be considered on a case-by-case basis, but by nature, if it's a disabling stroke, I end up taking these patients.
I think I tend to agree with you, depending on the, how devastating the symptoms the patient is presenting with, regardless of their NIH score and how distal the thrombus is. As you mentioned, if a patient is presenting with only aphasia will come with the low NIH score, but I think it's a very important thing to preserve in a patient who's presenting with such a problem, and you are able to, help him or save this, issue.
Yeah, I think we're looking for direction. Hopefully we'll have more direction in the years to come as we get more data on it. And hopefully the guidelines will reflect that. But the thrombectomy procedure has the newer devices are becoming safer, and we've developed a lot more experience with the devices that we can be more careful in the smaller branches now.
Yeah.
Thank you very much. I get the second question to Dr. Mohammed Al Kuwaiti. I don't know if you could help with this question, Mohammed, is in the borderline in terms of age group. And the question is, do you have experience on BFO closure in younger / pediatric patient caused by non-lacunar stroke? And by young, I mean as young as 9, 10, or 23.
Okay, so in the trials that were published, the positive trials, they had cases between the age of 18 and 20. Me personally, I don't have, I have my cases that PFO closure, I had few actually, but they were in their 20s and 30s. Trying to have a complete workup for these cases. It's not only the PFO, it's not only the embolic stroke, but you have to do a comprehensive workup looking at different aspects, trying to define why the patient had this stroke, including prolonged cardiac monitor, including doing imaging of the lower limb and the upper limb venous system, looking for DVT, and looking also at the structure of the heart by doing an MRI, and even evaluating this PFO using TCD, transcranial Dopplers, where you can define the severity of the shunt much better than a transesophageal echo. I think putting everything together and defining ESIS first before proceeding for a PFO closure.
Thank you. I guess some of the patient in post-prospect study on closure are even younger groups, some of them about 19 and 18. So some of the data may support approaching even younger group if the workup is done properly, obviously. Always the difficult question is related to the causation to the actual BFO itself. That often is a very difficult question. Thanks, Mohammed. Talib, you can take the second question.
Okay. So it's gonna be for Dr. Syed again. Do you think that the treatment window can be further extended in the future based on collateral score? Because most of the automated algorithms we have now will detect the core of the infarct and the penumbra, but I'm not aware about any algorithms or AI programs looking at the collateral score.
Yeah, so I mean, at this point in time, we have indirect markers of collateral scores. So like I presented the hypoperfusion intensity ratio on MR perfusion, and then obviously extrapolating CT perfusion. So in a way, I mean, you're using that as a marker, in some cases direct, in other cases indirect. But at this point in time, no, I'm not aware specifically of using AI for that in that particular scenario. But yes, we're already expanding the window. I mean, the window is up to 24 hours. And who's to say that the window should be only at 24 hours? I think one of my cases which showed natural evolution of a stroke on MR over 7 days with a very, very small diffusion core. I showed a slide of that over 7 days. It was significantly small. So every patient has different collateral flow and different perfusion parameters. And so I think, yes, the window will expand. We're going to move away from a time-based paradigm to a tissue-based paradigm. And I think we're already well along the way. So yes, I think that's the future.
Thank you very much.
Thank you. Question to Mohammed. There's a lot part of the world which is still having developed thrombectomy or even thrombolysis surfaces. And I have a question from a few of the audience. What will be the best approach in terms of therapy when you don't have any access to intervention?
That question to me.
Yes.
So in terms of trying to get trying to be part of a network where you can send your patients for intervention is always a good idea. Connecting yourself to a comprehensive stroke center or a primary stroke center where they can do all these procedures, including a PFO closure or thrombectomy, I mean, or TPA, and either connecting with them either by telephone or by telemedicine, by seeing the patient and treating the case through a camera. I think this is doable, especially in the low resource communities and patients who don't have even thrombectomy, for example, can be done in the low resource communities by non-neurointerventionalists. Like they can be done by cardiology. In some counties, for example, there's also neurointerventional, the body neurointerventionalists. Sometimes they do these procedures if the neurointerventional is not available. And I think the question was very broad. Was thrombectomy? Was TPA? Was not PFO?
I think the question, Mohammed, along the line, what will be the best option available if you are told you have no option of thrombectomy or thrombolysis in somebody present with acute stroke due to large artery occlusion and you have no access at all? You just have medical therapy. What will be the best medical therapy? And I think he put the question about dual antiplatelets and whether there's a possible role for anticoagulation. And I think he put an IH of 5 and a large artery occlusion.
So usually in patients in acute stroke, there's no role for anticoagulation. It's a very high risk of bleeding. And dual antiplatelets is usually recommended for specific cases. It has to be a TIA or a small stroke or patient with intracranial stenosis. patients who have large stroke or LV, usually patients who have LVO have large infarcts. And in these cases, using dual antiplatelets or anticoagulation might put the patient at risk of hemorrhage. And if you add Plavix to these cases, in many of these cases, they might need a PEG. And putting Plavix on board will delay the length of stay will increase and will delay the procedure in some cases. But I would recommend trying to connect to a network where patient can be transferred for acute therapy.
Fantastic. Thank you very much, Mohammed. Taleb? Taleb, you're mute.
So, Dr. Syed, I think we have a question regarding mechanical thrombectomy and collateral circulation. So,
Yes.
how can we predict the likelihood of reperfusion injury in patients undergoing mechanical thrombectomy, or even with thrombolysis? Any relation to collateral circulation?
Yes, so I mean, that basically, it pertains to the size of the core. So within the setting of acute occlusions, large vessel or small vessel, obviously the timing. So if we look at thrombolysis data and thrombolysis trials, it's based on age, size of the infarct, blood pressure control, underlying coagulopathy, hyperglycemia. So there are medical factors that definitely play a role. But volumetrically, the larger the size of the tissue. Within the era of mechanical thrombectomy, when we're doing perfusion imaging and we're looking at the size of the core, there's an estimate of that. Secondly, on angiography. So when we see that there are poor collaterals and the core is large, then the risk of reperfusion, hemorrhage, or injury does go up. And finally, there's some telltale signs after thrombectomy. So if we see early venous filling or deluxe hyperperfusion, every time I see that, I'm quite aggressive with lowering blood pressure. This is an area of research. There are ongoing trials we're looking at this, where in patients with extreme strokes, large cores that have been excluded from prior trials, if they undergo thrombectomy, what is the risk of reperfusion? Also, what's the best blood pressure lowering strategy? So a lot of us intuitively will lower the blood pressure as soon as we recanalize and reperfuse the brain. We drop it less than 140 by 90. Some people are more aggressive, less than 130 by 80. What's the data on that? So we don't have level 1 evidence on that. A lot of it is extrapolated from registries and trials, but there are trials underway both on blood pressure and looking at large ischemic cores. So in a nutshell, yes, there are patient factors, there are blood pressure, coagulopathy, sugar, and there are angiographic factors and imaging factors that dictate this.
Thank you.
I have a final question to Dr. Mohammed. How long would you continue dual antiplatelets, the aspirin and clopidogrel, as in the Express trial? Is that for 3 months, for a year, or lifelong?
So it depends on the pathology, what we're treating. Dual antiplatelets, usually I prescribe it for TIA and small strokes following the CHANCE trial, up to 3 weeks, and you can go up to 1 month. The POINT trial have shown that you can go up to 3 months. However, there's a slightly increased risk of bleeding. So I would say 1 month, 3 weeks to 1 month for patients who have TIA or small stroke. However, if the patient has history of intracranial stenosis, there's many trials like the Sampers trial and the VSET, where they compared putting a stent versus dual antiplatelets and aggressive medical therapy. The medical therapy with dual antiplatelets for 3 months was better. So I would, for these cases, I will extend it for 3 months. Usually after 3 months, we don't have enough evidence to say you can continue further to a year or 6 months. So up to 3 months is where the evidence stops there, to my knowledge.
And Mohammed, for this question, as a personal extension to the question, And in people with microbleeds on MRI scans, would you still go ahead and give dual antiplatelets, or will you be a little bit worried about the risk of secondary hemorrhage, even if they got extracranial atherosclerotic disease and they present with a TIA?
You know, usually stroke risk is up front. It's in the first few weeks. So if I can get away with a few weeks of dual antiplatelets, I think the patient will benefit. So I might suggest it for maybe instead of doing a month, I can do it for a less period of time. Let's say for 10 days or 2 weeks or even a week overlap, because the stroke burden is usually at the beginning. Stroke risk, I mean, the highest stroke risk. And I tend to keep the patient at least on a single antiplatelets. It depends on how bad is the microbleeds. If there's any signs of amyloid angiopathy, that's another thing. And yeah, I try to give the patient the best possible prevention plan. If it's amyloid angiopathy, I try to stick to only a single agent, and sometimes I try to avoid antiplatelets in some cases. Blood pressure for severe amyloid angiopathy, blood pressure control is the way to go, I see. And however, there's some article where they recommend, they still recommend using antiplatelets. And in some cases, if there's AFib, I've seen patients who have history of, let's say, lobar hemorrhage, they still recommend you can still anticoagulate these cases if they have AFib and a history and stroke, but had a history of lobar hemorrhage in the past.
Fantastic, thank you very much. Talib?
Okay. I think I have a more generic question for Dr. Syed. It's about blood pressure management for those patients coming with high blood pressure with either ischemic stroke or hemorrhagic stroke. What will be your target and how aggressive you will go down?
Okay, so I think for ischemic stroke, it's very clear. I mean, the stroke guidelines state that quite clearly. If there's thrombolysis, if TPA is on board, then we less than 185 by 105 is our threshold. Otherwise, permissive hypertension within the first 24 hours, up to 220 systolic. For intracerebral hemorrhage, right now in our practice, and again, guideline based, less than 160 by 90, aggressive lowering of blood pressure more than that has not really been shown to improve outcomes within the first 24 hours. Recanalization, reperfusion, which is outside of a guideline, we currently do less than 140 by 90. So that's it in a nutshell, but I would refer the person who's asking a question to the guidelines. It's very clear about what we should do for blood pressure.
Dr. Isam, do you have any questions?
Yeah, Dr. Syed, what is your experience in the challenges facing us with basilar artery and posterior circulation strokes in terms of using the CT perfusion and using various technologies in selecting this patient who will come delayed? Do you go for MR or do you still continue using your CT perfusion with the limitations?
Yeah, so we've moved towards MRI. So in the posterior fossa, as Dr. Isam is alluding to, we have very good CT angiography and collaterals, but it's such a small area that to generate perfusion maps is hard. You can get some perfusion maps of the cerebellum, the cerebellar hemispheres, but within the brainstem, it gets a little challenging. But for basilar artery circulation, if it's hyperacute within 6 hours, most of my colleagues and I will just take the patient. If it's longer than that, within 24 hours, we'll still take them, but we like to get a hyperacute MRI prior because we just actually had one patient last week within 6 hours presented to us, but the pons was wiped out, completely wiped out. And then, those are patients that we could actually make worse with reperfusion hemorrhage. So I think MR is more reliable, and that too is to get an assessment of the extent of ischemia within the brainstem, to get an extent of the core. And we don't really look towards perfusion in the posterior fossa as much.
Thank you very much.
You're welcome.
I think we reached the end of our webinar for today. I would like to thank Dr. Syed Irteza Hussain, Dr. Mohammed Al Kuwaiti for their participation and enriching our webinar series. Also, I would like to thank my fellow colleague, Dr. Isam, Salih. Thank you very much. And to all attendees, I would like to thank you for attending this webinar. I mean, without you, this webinar series wouldn't be successful. And all of you, there was a question about the certificates. You will get your certificates by email, I believe. I think with your registration, you submitted your emails, and you will get it by email, inshallah. Okay. Thank you very much, all, and good night.
Thank you. Thank you all.
Thank you.